What I'd like to do during this next session is talk about incidental soft tissue lesions. And I think it might be more appropriate to have this as lesions of soft tissue that are often seen as incidental findings, but may in fact be a primary source of an issue. And but that was a little too long to put for a title. So many of these are true incidental findings, although some of the examples that I'll use really are for patients that came in specifically with this abnormality. And really when to worry about these, because many of these lesions that we'll talk about can be seen as incidental lesions, and how we can separate those that need really definitive further workup as to those that we can dismiss just on the basis of imaging alone. So specifically at the completion of this session, I'd like you to recognize common incidental soft tissue musculoskeletal lesions that may mimic more serious disease, and you should be able to identify distinguishing features so you can separate those that are true incidental findings from those that do require follow-up. And we're just going to talk about some of the simple ones, the ones that we see with frequency, and the four that I've chosen to address are those that are listed here. And we'll begin with the soft tissue lipoma. Lipomas are incredibly common. They are tumors of mature adult fat, and although nobody knows the true incidence in population studies, it is something that certainly is commonly encountered. And in one large population study from Scandinavia, they estimated that it's about 2.1% of the population. It is a fact that in the United States, about 50% of those patients that come in for evaluation or surgery for a soft tissue tumor, in fact, have lipomatous lesions. In that case, benign lipoma is certainly far more common than malignancy. So it is something that we see with great frequency. Usually presents in people in middle age, in that classic 40 to 60-year-old age group. I like to say that age at which you can start to see the dark at the end of the tunnel. Men and women about equal age predominance, although some of the new studies will show a male predilection, and they're typically superficial with deep lesions, less than 1% of all of those, but certainly because it's such a common lesion, we do see them, and they're often more typically the ones that we do image. Typically asymptomatic, more common in obese patients, usually small, although certainly a small number can be greater than 10 centimeters, and because they're made of fat, they image identical to adult fat on all imaging modalities. And although the fat within a lipoma is identical to adult fat, it is genetically different in the majority of cases. And now about 80% will have clearly defined genetic abnormalities to separate it truly from normal adult fat. On imaging, we see a fat attenuation mass that will parallel the signal or the imaging features on both CT and MR. On CT, usually a low attenuation. More important than the number is how well it corresponds to the patient's subcutaneous fat, because my fat may be different than your fat, or the fat in the anterior abdominal wall may have a different Hounsfield unit or tissue attenuation than that in the posterior abdominal wall. And that visual comparison is very important. On MR, again, should parallel fat on all pulse sequences, and the lipomatous portion of the lesion should not enhance following the administration of contrast. Most commonly, we will see subcutaneous lipomas, and they can be difficult to evaluate because they're within the subcutaneous adipose tissue, and that's the most common location, and because they blend in with that, they often can be very easy to miss. And here are just two examples of an upper extremity with subcutaneous lipomas to emphasize how subtle they can be sometimes. They can be nicely seen on CT as well, and we make the diagnosis when we have a lesion that has an attenuation identical to that of the subcutaneous adipose tissue, and you can make that diagnosis with confidence. Occasionally, I'll see reports of somebody that'll say something, lesion has the signal intensities or attenuation similar to that of subcutaneous fat, likely a lipoma, but cannot rule out liposarcoma. I would say, you know, if it looks like a duck, quacks like a duck, it's a duck, and if it looks like fat on everything, it is certainly, you can make the diagnosis of a lipoma, I think, with great confidence. On ultrasound, they typically will be well defined. They will have some linear echogenicity within it, and the signal intensity or the echogenicity will often be similar to or slightly hyperechoic to normal adipose tissue, can be somewhat lower. It is quite variable. Classically, they will show no or very minimal vascularity and will compress under the ultrasound transducer. And so you can make the confidence again with ultrasound as an incidental finding, as this was, with great confidence. And this was a patient that was having a gallbladder ultrasound. And when we looked at the, not that I read the gallbladder ultrasound, but it was brought to my attention on the basis of the ultrasound for the study. And when we went back and looked at his CT imaging done about 2 years previously, really a very nice example of a subcutaneous lipoma, again with a signal really, or an attenuation identical to that, in this case even a little more homogeneously adipose than the surrounding tissue. And here another lesion in the posterior adipose tissue, again an incidental lipoma. We see the signal intensity identical to that of the subcutaneous adipose tissue. These lesions will very classically have a fibrous capsule surrounding them, although that's not invariably present. It typically is. Occasionally we will see it without that, but most typically present, and of course the adipocytes within it with their peripherally displaced nuclei. And these are lipid-filled cells, and so as we see it, the vascularity tends to be compressed and pushed, and they look relatively avascular and typically will not show any enhancement following the administration of contrast. While they have a classic capsule, we can see them as unencapsulated masses, as shown in this case, and it's really not clear in these cases if that capsule is there and just too small or too thin to identify on imaging, or not there at all, and that's one of the questions that needs yet to be answered. They can have significant fibrous septation within them, as shown on this, and as you would expect, something that's fibrous will be dark on all pulse sequences typically seen, and following the administration of contrast, you can see some enhancement in that fibrous septations between them, but otherwise the fat itself should not enhance. And this, a lipoma with fibrous tissue within it, the most common variant that we see on simple lipomas, and sometimes the pathologist may call this a fibrolipoma because of the fibrous tissue when there is a significant amount present, but that is not a specific diagnosis as recognized by the World Health Organization. Typically, when we see them deep again, the signal intensity will mirror that of the subcutaneous adipose tissue on all pulse sequences. And here, a patient with a large mass within the muscle. You can see on T1 and fat-suppressed imaging, in this case a STIR image, the signal intensity again mirroring that of the subcutaneous tissue. And this was a patient actually who had this as an incidental finding, and the question was, is this something to worry about? And when I look at the fat within a lipoma, I always like, particularly when it's done with a surface coil, to compare it to the fat at a similar distance from the surface coil to see how well they compare. In this case, it was virtually identical, and I was very happy to make the diagnosis of a lipoma, in this case intramuscular because of its location, and the same thing on the T2 weighted image, and this was confirmed as surgery. Now, we often think of lipomas as distinct lesions, and they have to be pure fat, but sometimes they can infiltrate, and we always think of infiltration as a bad thing. Now remember, soft tissue tumors, when they grow, tend to compress the tissue surrounding it and form a pseudocapsule. Lipomatous lesions on occasion will infiltrate them and have this very infiltrating margin that could be well defined but infiltrating, and we can see the fat interdigitating between the muscle in this intramuscular lipoma. And actually it's not 100%, but it's nearly 100%. When we see this margin, that's typical of a benign intramuscular lipoma. We don't see it all the time, but certainly when we see that, that's indicative of a benign process. And here, following the administration of contrast, you can see some of the vascularity within it, but certainly everything else images as muscle or fat, very indicative of an intramuscular lipoma, in this case with that infiltrating margin. And here just some enhancement of the vascularity within it. Now I bring that up for another incidental finding in this patient that was being evaluated on a lumbar spine, and you can see the fat, and within it there's some non-adipose tissue, but the signal intensity of that mirrors that of muscle on all pulse sequences, and again indicative of an intramuscular lipoma. And on this long axis imaging we can nicely see the muscle striation, the muscle or the striated muscle extending within the adipose tissue. A confident diagnosis can be made of an intramuscular lipoma here with some infiltrating margination. We see lipomas in all sorts of odd cases, and when the signal intensity or the attenuation mirrors fat on all of those, we're very happy to make it. And this was an incidental on body CT lipoma of the esophagus, and more commonly on body imaging lesions such as this incidental lipomatous lesion as well. So when do I worry? Well, I worry when it's not completely fatty, especially when the non-fatty component is not identical to muscle, or when it's irregular or thickened, globular, or enhances significantly. So, and one other thing, when it's in a location, particularly in the retroperitoneum, because we know that well-differentiated lipomas or lipomas themselves are very rare in the retroperitoneum, and most of the fatty masses within the retroperitoneum that image like fat are in fact low-grade liposarcomas. So what do they look like when we call it a well-differentiated? Well, they're usually mostly fat, but they have these irregular or nodular thickened septa or globular areas of increased non-adipose tissue. And while a small number of lipomas may have that imaging appearance secondary to fat necrosis, when we see that on imaging, we always suspect a liposarcoma. So for example, if we saw this in the forearm radiograph on the left of the screen, and we take a look at it, you can see the mass, and when we look at this, we can see these thickened irregular septations. Although it's a predominantly fatty mass, when we see this, this is a low-grade malignancy, and this is what would be called a well-differentiated liposarcoma if it's in the retroperitoneum. When it's in the extremity or an area where there can be complete excision, the term atypical lipomatous tumor is now used to describe this process. It's a low-grade borderline malignancy with a tendency for local recurrence, but not metastases. And again, we can actually see that the fat within it, in this case, has somewhat higher attenuation than that of the adjacent subcutaneous fat, although that statistically is not significant in differentiating benign and malignant lesions. And here just the T1 weighted image long axis, nicely showing those thickened irregular septations within it. Again, retroperitoneal lesions always suspicious no matter how benign they look for malignancy. So lipomas are common. It's a fatty mass. They may have some fibrous septations, and they occasionally, when we have a lipoma that is involutional change, particularly fat necrosis, it may mimic a low-grade liposarcoma, but certainly it can be impossible to make that distinction sometime on imaging alone. But when it doesn't fit into the simple appearance that we talked about, certainly further workup is necessary. One of the most common skin lesions that we see incidentally is truly an epidermal inclusion cyst. It used to be called a sebaceous cyst, although the pathologists really don't feel that it's of sebaceous origin and have changed that terminology to epidermal inclusion cyst. for a short time in between, was even called an infundibular cyst, because it's a result of a cystic ectasia of the infundibular portion of the hair cell, and hence that term infundibular cyst was used for a while. And it's secondary to some process that causes a mechanical obstruction in the hair cell. And if we take a look at the skin and look at the hair cell, with this portion of it here being the infundibular portion, there's some obstructive phenomena there that backs up and causes this association of proteinaceous fluid within it, causing this epidermal-like inclusion cyst. And as you can see, because of the location of the hair cell, it should be immediately adjacent to the skin. And that's really very important in making the diagnosis. They're most common in the head, neck, and trunk, in the back area. They're usually small and solitary, and an easy diagnosis. They certainly can rupture and cause a foreign body reaction or a granulomatous reaction, and occasionally even get infected. But in general, that's unusual, and typically it's a well-defined ovoid or lobulated lesion that's immediately adjacent to the skin, and in about half of the cases we can actually see some scalloping of the skin secondary to the mass effect of the lesion, which I find to be one of the most useful imaging features of making the diagnosis. The signal intensity will vary. They certainly can have some debris within them. Often they look fluid-like or proteinaceous fluid-like, and classically there's a very definitively enhancing rind at the periphery of the lesion if contrast is given. This is the typical on MR appearance of an epidermal inclusion cyst. We can see the cyst-like nature to it. We can see how it scallops the skin, and this is a beautiful example of that, and the corresponding ultrasound, and that scalloping again is seen in about 50% of cases. Because it often has a very proteinaceous fluid within it, you may see some increased fluid transmission, but ultrasound can show increased echogenicity, as demonstrated here as well. Following contrast, again on the fluid signal on T2 weighted images, following contrast we can see enhancement of the rim, and sometimes on fat suppressed imaging you'll see an increased signal secondary to the proteinaceous nature of the fluid within it. And here just a higher power view of that area showing the enhancing rind with the proteinaceous fluid centrally. Here another patient with a subcutaneous lesion immediately adjacent to the skin. It's hard to see the scalloping of the skin because of the larger field of view, but we certainly can see some dependent area of decreased signal, again secondary to some dependent debris within this epidermal inclusion cyst incidentally noted on MR imaging. And here another patient being evaluated of his thigh for pain in the thigh, relatively nonspecific with this epidermal inclusion cyst, which was subsequently excised and confirmed. And on axial imaging we can see the lesion, again a little bit of a noisy lesion, but you can get the feel for a little bit of scalloping of that skin and the relatively cyst-like appearance of the lesion. And ultrasound very nicely shows the skin scalloping, as well as a very similar picture with increased echogenicity within the lesion, representing the sebaceous, or representing the proteinaceous fluid within it. And nice scalloping, as we talked about a moment before. Now, when do I worry about skin lesions in general? I worry when they're solid, when they show enhancement. I worry when they're painful. I worry when they show associated inflammation. And although benign lesions can grow, I do worry when I get a history of growth or continued growth. If you look at this, you might say, well, geez, that axial T1 weighted image really shows the lesion to be scalloping the skin. It has a cyst-like appearance. Why isn't this an epidermal inclusion cyst? And I would say, yeah, that's a very reasonable differential consideration, and I would probably like it for that first above all else. But then what am I going to do with all this inflammation around it? And you can see following the administration of contrast, the enhancement in that area. And of course, this was an epidermal inclusion cyst. in this case with really significant inflammatory change surrounding it because it was infected growing actinomyces. And here, another skin lesion with little tapered edges growing along the margin of the skin, and we can see some heterogeneous signal intensity following the administration of contrast. It enhances intensely, and this was an epidermal, and this was a dermatofibrosarcoma protuberans, actually one of the most common soft tissue sarcomas. We don't image it that often because they're usually excised by dermatologists, but when they get large, we do, as in this case, and it represents about 6% of all soft tissue sarcomas, so not an uncommon finding if you work in an oncology hospital or patients where there are a large number of oncology patients. So, epidermal inclusion cysts, small, well-defined, ovoid, solitary lesions, variable signal intensity depending on the contents, can have some debris, and will scallop the skin, a very nice finding on both ultrasound and MR in about half of the cases. Now we'll talk just a moment about ganglia. Ganglia is not a true tumor. It is a tumor-like lesion that was recognized by Hippocrates in antiquity, and he described it as a knot of mucoid flesh. And it is classified by the pathologist as a myxoid lesion, which certainly makes sense. It's formed from a coalescence of small cysts formed by myxomatous degeneration of the periarticular connective tissue. And if you believe that definition, which I think most soft tissue pathologists would agree with, it doesn't make sense that it communicates and is just an extension of joint fluid. And I think the feeling in the pathology community is that it is not, that it is a degenerative phenomenon as described here. Now, if you look through the soft tissue pathology textbooks, you'll see statements such as this. When they talk about ganglia, there's no communication between the ganglion and the joint space. If you read through some of the orthopedic literature, you'll read things like about the typical ganglion cyst that consists of a cyst sac that communicates through a stalk to the underlying joint or tendon. And it is interesting to note that in a more recent study where they looked at 45 cases, the stalk was identified in only 9%. And I do think from my own experience, and again, I would have to qualify this as anecdotal, that I don't think they arise from joints. I think they arise next to it in that juxtaarticular connective tissue. But after they're long standing, it's not uncommon to see a communication with the underlying joint or tendon sheath. So I kind of like that idea. I think that really reflects how they originate, but I do think they can communicate with the joint. Now, there is no accepted classification for system for ganglia. And actually, when you find out, there really are a whole different number of that can be, that are described in different locations. Whether it be juxtaarticular, intraarticular, associated with the nerve, adjacent to the periosteum, or even digital with these mucoid cysts are considered ganglia. But for this purpose today, we'll really only talk about the conventional juxtaarticular ganglia. And I do want to mention the ganglion-like paralabral cyst, which can have a similar imaging appearance, but really has a different pathophysiology. And we'll look at that first. The paralabral system we talked about a few minutes ago was mentioned, sometimes called paralabral ganglion, pathophysiology of a meniscal cyst in the sense that there's a tear of typically the labral area and extrusion of joint fluid through a labral capsular tear that accumulates. And we actually see these as incidental findings, not that all infrequently. Hip and shoulder are most common. Certainly they can be symptomatic, but incidental ones are really quite common, particularly in what I would call mature adults. This was a young woman who came in for evaluation of her inflammatory bowel disease, had these CT images, and the lesion around the right hip was really not identified prior to her referral. She had evaluation of her abdomen, again looking for inflammatory bowel disease, and again, the lesion was there, but again, not really noted prior to her arrival. When she came in for evaluation of her bowel, she had an MR enterography, and it was much harder to exclude this in this area, and certainly we suggested it was likely a paralabral cyst because of its morphology and location. But in any referral center, nothing goes, it probably is. And of course, follow-up imaging located directly to the hip was needed to prove that the cystic area was arriving from that was a paralabral cyst secondary to a tear of her superior labrum, which was nicely demonstrated on the more dedicated hip imaging on MR. Certainly, superior labral area is the most common, but we occasionally will see it medial, as in this case. And again, this was another incidental asymptomatic finding in a mature adult secondary to a torn labrum. And it's very common around the shoulder, and here we can see it from paralabral cyst extending posteriorly, again from a tear within the posterior superior labrum. Now, when we talk about the juxta-articular ganglion, they can be associated with pain or sometimes functional impairment, and sometimes even with a nerve palsy, depending on where it is, probably most locally or most commonly seen in the shoulder, but occasionally in the wrist as well. Microscopically, these are thick-walled cystic lesions with myxoid areas within them that are very rich in hyaluronic acid and mucopolysaccharides, and they typically have a very high fluid signal on fluid-sensitive sequences. So this is the classic ganglion, this myxoid material, and typically is associated with cystic changes as shown here, but they need not be present. And sometimes, for those of you who have aspirated ganglia, you know that you get this very thick, gelatinous-like, mucousy-like fluid from them. Here are the typical ganglion associated with tendons over the dorsal aspect of the hand, a very classic appearance, the old Bible cyst, the idea being that once they are beaten up with a Bible, they will dissipate and collapse. And so here, imaging of one of these cyst-like lesions, we can see the cyst-like character to it, a little enhancing wall, very nicely demonstrated. And of course, if you aspirate these, you'll get this thick, tenacious fluid, and certainly aspiration with a very large gauge needle is required to decompress these. Now, it's important to note that because these are myxoid tumors, or myxoid lesions, I should say, that myxoid component does have a vascularity to it. And so sometimes you will see some areas of definite enhancement within these. Here we see a small ganglion adjacent to the volar aspect of the wrist. We can see the radial artery adjacent to it. And following the administration of contrast, there really is a fair amount of enhancement there. And that usually doesn't dissuade me from the diagnosis. I recognize that, particularly when there's a predominantly myxoid appearance, more often in the smaller lesions, there can be significant enhancement, as in here, and the diagnosis of a ganglion was made. If someone said to me, well, why couldn't it be something else? I would probably say that common things are common, and the one that we most commonly see around a joint with this type of an appearance is a ganglion. I'd be very happy to do nothing but follow it, which was done in this case, and actually it got smaller over time, and that was the end of it. Very commonly, they'll have this multiloculated appearance as shown here, and we see this nice example of an incidentaloma of this patient who's had his thumb evaluated, and notice how it has that multilobulated appearance, a very characteristic pattern of growth for this type of a lesion. And certainly we very commonly see them when we image the knees around the attachments of the gastroc tendons as shown here. And I like to call this the sort of the bunch of grape appearance, which I think very nicely describes what it looks like on MR imaging. And we can certainly see it around the wrist as well. So these, the ganglia, and these all asymptomatic lesions. So when do I worry? I worry when they're symptomatic. I worry when they have an atypical location. They should occur around, if we say it's a process of degeneration of the synovial tissue, it should only arise around synovial-line structures. I worry when there's increased vascularity, and I worry when it has a gross or a mass-like pattern of growth. So ganglion, common, variable appearance. They may not be purely cystic, as we talked about, and sometimes they can certainly cause symptoms. The last thing I want to talk about is just synovial cysts. The classic synovial cyst is the popliteal cyst, originally described by James Morant Baker, the Baker cyst, in the 1800s. And it's a result of the communication between the knee joint and the normally occurring gastrocnemius semimembranosus bursa. We know that there's an increased incidence of these with age as we break down the connective tissue about the knee, and we can get extension of fluid from the knee joint into this normally occurring bursa. Can be associated with meniscal injury, and in a large series, about 5% of the knees that were studied in over 1,100 cases had synovial or popliteal cysts, and we tend to use the term popliteal cyst specifically for that communication with the knee joint and the normally occurring gastrocnemius semimembranosus bursa. Usually asymptomatic, sometimes even when they're quite large, although rarely they can cause pain and symptoms of internal derangement. They can dissect and even simulate a DVT, but these are synovialized spaces, and that synovial tissue, that thin layer of synovium, is lined by a fibrous wall, and that makes up the margin of this fluid-filled cyst, and it should have a fluid-like signal intensity on MR and CT. And here we can see the margin of a synovial cyst, where you can see that single cell line of synovial cells with the fibrous tissue surrounding it, and this the wall of the synovial cyst. So where do they look like? Well, what do they look like? This is what they typically look like. And you can see the semimembranosus and the medial head of the gastroc tendons and the fluid associated with it. And that fluid can pretty much go where it wants. So if you look at the knee joint and find the sartorius, the gracilis, the semimembranosus, and the semitendinosus, and follow it down to the joint, when you see that semitendinosus and gastrocnemius tendons, that fluid collection has to be between them, and that's the normally occurring gastrocnemius semimembranosus bursa, and that's where it should be. And if it's not there, it doesn't meet the imaging requirements for a popliteal or synovial cyst arising from the knee joint. So between those tendons is very important. And once there, it can dissect laterally posteriorly, medial posterior, medial anterior, or lateral anterior. It can go and dissect wherever it will want to, but certainly it has to arise in that location and fill that particular bursa. Okay, so why is that important? Well, it's important because, again, this is a lesion defined by its anatomy. And sometimes we can see some septations within it, as in this case, and those septations can show enhancement following the administration of contrast. But again, important for the location, and here the corresponding CT. When it dissects, it tends to dissect along the margins of the gastrocnemius, and again, because this is fluid-filled, the signal intensity from the lesion should match that of the fluid within the joint. And here we can see a lesion extending down the gastrocnemius, a more typical location for the dissection. When do I worry about synovial cysts? I worry when it's in the wrong place. And working at a referral center, we get a lot of masses in the popliteal fossa that are referred as popliteal cysts when in fact they are not, because they don't meet the anatomic requirements, or when they're not cystic, or when they image like a mass. So some examples. This is a patient with a popliteal cyst, but you can see some densities within it, and this was synovial chondromatosis in association with a popliteal cyst. And certainly we know that because this is a synovial-lined structure, it is subject to synovial lesions, or those lesions that arise in synovial-lined spaces. Here, another patient with a popliteal cyst. We can certainly see the appropriate location, and we can see the large fluid-filled mass in T1 weighted image on your left and gradient DES image on the right of the screen, and we can see the blooming from the nodular areas or frond-like areas of opacity or decreased attenuation at the periphery of it in this patient with what now would be called intra-articular diffuse tenosynovial giant cell tumor, or what we used to call pigmented villonodular synovitis, that affected both the popliteal cyst and the knee joint. And here, just from the arthroscopy of that patient, showing the really beautiful example of what we used to call PVNS. And this probably the most important case. This was a 12-year-old who was playing soccer, hurt his knee, and had an MR of the knee. And while he had the MR of the knee, this was called a popliteal cyst. And I certainly agree he has a rounded mass or an ovoid mass adjacent to the knee. You can see it there on axial fat suppressed imaging. We can see it on a T2 sagittal, and we can see the mass, and it has a signal intensity that's not even close to fluid. We can see some areas on the fat suppressed T2 or the fat suppressed PD images that are decreased on the non-fat suppressed image. And when it was finally correlated by the orthopedic surgeon that he was sent to for this popliteal cyst, they took a radiograph, and of course it showed these calcifications within this mass in this synovial sarcoma that was initially diagnosed as a popliteal cyst. So, synovial cyst, common, should image as a cyst, may be complicated by hemorrhage, synovitis, loose bodies, etc., but certainly it is a lesion that is defined by its anatomy, and if you keep that in mind, you certainly would have no problems in making the appropriate diagnosis. So in summary, incidental MSK lesions may simulate more significant disease, and close attention to the imaging features will usually now allow a very accurate and definitive diagnosis. I'd like to thank you very much for your attention during the lectures, and anyone who would like a handout, please feel free to email me at that address, and I'll be happy to forward it to you, but I probably won't be back for another week or so, so it may be delayed in its return. Thank you.